Histotripsy is this new therapy, which we're focusing on today, no pun intended, but of using ultrasound to destroy the tumor, not with heat, but with kind of cavitating ultrasound waves that robotically deliver bursts of ultrasound energy to little areas. And then it's almost like 3D printing using imaging and ultrasound imaging to destroy the tumor with adequate margins in locations that can't be surgically removed sometimes.
Welcome to Beyond the Rounds. Today we're talking about the future of surgical cancer treatment. My guest is Dr. Michael Choti, Chief of Surgery at Banner MD Anderson Cancer Center. He is a surgical oncologist who trained at Yale, Penn, and Sloan Kettering, and formerly chaired the Department of Surgery at UT Southwestern. By the end of this episode, you will understand what histotripsy is, why it might be the biggest leap in liver cancer treatment in decades, and why we still need to be cautious about some of the hype that surrounds it. Dr. Choti, welcome to the show.
Thank you, Nolan.
Well, you've been doing this for 30 years now. Can you take me back to the start? When you decided that you were going to go into surgery, what was it that brought you to this field?
It's interesting. It wasn't like it was a planned strategy the whole way. I mean, I'm interested in medicine, pursued medicine, and often role models and who you spend time with during medical school. And I really was interested in pursuing surgery. And so I went to University of Pennsylvania and was going in that direction. Great mentors, great role models, surgical oncology, and then pursued that. So it's really the cancer surgery is the great. I love what I do, dealing the complexity of both the technical surgery, obviously the psychosocial aspects of dealing with patients and families that were dealing with such a crisis in many cases, and also the complexities, the science of oncology is just remarkable. So it's been a great career, and I enjoy it very much.
It's been a wild ride.
It has been, yeah, absolutely.
And so you've seen a lot change then.
Yes.
What in the last 10 to 15 years has been most surprising to you about the surgical treatments that you use?
Well, so much of oncology is evolving. I mean, it's on the one hand, the cancer diagnoses in young patients, everything is just accelerating. Unfortunately, it's becoming so more and more common, unfortunately. But on the other hand, so many advances are going on. All the other molecular genetics, personalized medicine, AI, and also. But as you ask, surgical innovation and technical innovations have also been dramatic, and including a lot of these technologies, such as the molecular genetics that allow better selection of patients to undergo surgery, for example. So before, you don't always know if you're helping patients. So we're now able to refine our surgical procedures to perform operations that have better outcomes, in part because of better patient selection. But from a technical standpoint, certainly the techniques that we use, the robotic surgery, for example, has allowed us to do complex operations using more minimally invasive incisions and image guidance, for example, so we can fuse the imaging done preoperatively to help guide us during surgery. So a lot of technical advances.
That's interesting. You said that younger people are developing cancer, it seems like at a higher rate. Do we know why that is?
We don't. And GI cancers, we're going to be talking about liver cancer, colorectal cancer, pancreas cancer. Those cancers the incidence is going up significantly, and it's a little bit scary. Why in younger patients, colorectal cancer particularly, the incidence is going up in younger patients? We don't know why. Is it diet? Is it lifestyle? We don't know. But it is, it's a little bit, it can be scary. And it's changing our screening guidelines, for example, to younger patients, to starting to screen at earlier ages for that reason.
So there's a lot of cancers that you just mentioned. Is that primarily what you treat? Is GI, colorectal cancer, pancreatic cancer, liver cancer? What other conditions do you typically see?
Yeah, I mean, my training in cancer surgery, obviously it's broad, breast surgery and all kinds, but my career is focused on gastrointestinal cancers of the upper GI tract, stomach, liver, pancreas. And so I do right now, I'm really mostly liver and pancreatic cancer, as well as neuroendocrine cancer, stomach cancer, and then colorectal cancer. Colorectal cancer is interesting because one of the common places that travels from the colon can spread or metastasize to the liver. That's one of the common places. So a lot of the liver surgery and liver therapy I do is often for colorectal cancer that's spread to the liver. And that's why a liver cancer surgeon often deals with colorectal cancer.
Is that because the blood supply from the colon goes directly to the liver?
That's kind of a myth, kind of wives' tale a little bit. That it's like that, but there may be something to the blood flow from the colon to the liver. But no, the reality is we don't really know why the seed and soil, why the metastatic cells tend to grow or can spread to the liver. But it's a place where the liver is a common place where a lot of cancers spread to. Pancreas cancer can often spread to the liver, stomach cancer to the liver, even lung cancer or other breast cancer can go to the liver. So we don't know why.
Those wives' tales, they got me through medical school.
Yeah.
In regards to the liver cancer, then, what treatments have you used in the past, and how's the treatment of those liver lesions changed over, say, the last 15 years?
Yeah. So first of all, about half the cancers we treat in the liver surgically are metastases, as I mentioned, from other sites, and about the other half are so-called primary liver cancer, either hepatocellular carcinoma, which is cancer starts from the liver cells, often associated with viral hepatitis or alcohol consumption, or cholangiocarcinoma, bile duct cancer, which can start in the liver. And so how they're treated, it depends a little bit on the type of cancer and the location and so forth. But the often surgical therapy is done, and often we can cure patients, even with metastases to the liver. The one that's kind of the standard and still often common is surgical resection, cutting out part of the liver that contains the cancer and preserving, of course, the uninvolved liver so that it will function normally. And the liver is a unique organ. Patients love to hear this, is that it regenerates. It regenerates dramatically. I mean, I can surgically remove 70% of the liver. And as long as the blood supply and the branches are all preserved, within a month or two, the full volume regenerates. It's really the only organ in the body. It's like I tell patients, it's like a salamander's tail. It just grows back. So it's really remarkable. And so it allows us to do surgical resection often in many cases, and patients can do quite well. As I mentioned, these minimally invasive techniques, robotic, minimally invasive surgery, now we're able to do even complex liver resections done minimally invasive robotically sometimes. But sometimes it does still require open surgery. And then besides the liver resection, now we have newer ways or other ways that tumors can be destroyed within the liver, sometimes using, we're going to be talking about today, histotripsy, which is a new technique of destroying. It doesn't remove it, but it destroys the tumor in situ. But other therapies, thermal ablation, microwave, radiofrequency ablation, cryotherapy, radiation therapy can sometimes be focally delivered for radioablation therapy of tumors in the liver. So there are a variety of non-extirpative to locally destroy tumors in the liver.
So basically, it's moving to a more minimally invasive technique standpoint, as well as developing new technologies that don't involve any invasive, cuts or incisions at all.
Yeah, absolutely. But remember, the goal of this is still to provide the best oncologic outcome. So we don't want to be doing, it's less invasive, but then we're compromising the curative potential, for example. So these are not going to be replacing liver resection, for example, in many situations. In fact, one of the most common reasons I use, for example, something like these ablative therapies are in situations where patients aren't eligible, can't have liver resection, or their frailty or whatnot. There may be comorbidity or other indications that they can't do the most definitive therapy that is most effective, which is resection. So we then may use a non-resection approach. But as we get better at image guided, at precision, at destroying tumors precisely, it may be that these non-invasive, not only they're less invasive, but they may be comparable to surgically removing cancer in the liver, for example.
I'm a PM&R doc, so function to me, seeing these patients in rehab hospitals after they have these surgeries is very important. Have the techniques changed over the course of your career to focus more on outcomes outside of just the surgical removal of the tumor?
Absolutely, very important. Even patient-reported outcomes are extremely important in getting patients back to what they want to do and what they need to do. And so, whether it's big operations on pancreas or liver, the not so much even the minimally invasive, but prehabilitation is one of my favorite. We very aggressively now in patients who undergo surgery, operations for cancer, to really very proactively have a prehab program that involves physical, exercise, nutrition, and even psychosocial components that really make the recovery that much better.
And optimizing the other aspects of their health, of course, can be a safer surgical candidate, but improve outcomes then in the future.
Absolutely. Yeah.
So let's go to a case. We mentioned histotripsy before. I want to go into a case that showcases how histotripsy can be used, okay? So let's just say that we have, and this is completely a hypothetical case. Let's just say we have a 65-year-old male with a history of colorectal cancer, had a primary tumor that was removed 2 years ago, but surveillance imaging revealed 2 metastatic lesions in the liver. One of the lesions is deep in the right lobe and sitting right next to a major hepatic vein. What is the issue with treating this lesion that is next to the hepatic vein?
The first step is, in a patient like that, the goal is to get rid of those metastases, because unlike some cancers where once you have even one metastasis, it tends to portend that it's more of a disseminated disease. In colorectal cancer, you can have oligometastatic disease, and we often will get rid of those metastases, often in combination with systemic chemotherapy or systemic therapy. But many can be cured by going after those, as opposed to some cancers where if you just give chemo, it's just a kind of a palliative or life prolonging, but doesn't cure. So the goal in this scenario that you're presenting is to, probably in combination with chemotherapy in some cases, but to remove those or to get rid of those tumors. There it involves a careful imaging assessment to determine, as you imply, the proximity of these known metastases to vital structures. Working on the liver is it's almost like pruning a tree a little bit. Depending on if it's involving a main branch, then that branch needs to be dealt with. And if it's involving the trunk of the tree, you can't take the trunk out and still the tree survives. So it depends a little bit on the location as to whether this is resectable. So in a patient who's fit and this age, even if it's against a vein or whatever, depending on where on the vein and so forth, liver resection may be still the best option for this patient. But again, because of the complexity, the morbidity, or as you're maybe implying, if it is in a location that is not resectable, then the question is, what other therapies can be done? If it's next to a vein, sometimes thermal heat ablation can be done using like microwave ablation or something. But that is also not optimal next to a major vein. It can destroy the vein, and particularly if it's near a bile duct or other vital structures that can't be destroyed, or if there's so-called a heat sink from the blood, the blood flow within that vein that prevents the thermal destruction of that tumor. So there may be locations in which thermal ablation is. Histotripsy is this new therapy, which we're focusing on today, no pun intended, but of using ultrasound to destroy the tumor, not with heat, but with kind of cavitating ultrasound waves that robotically deliver bursts of ultrasound energy to little areas. And then it's almost like 3D printing using imaging and ultrasound imaging to destroy the tumor with adequate margins. And this therapy is unique because it really is independent of the blood vessels with regard to delivering the treatment. But more importantly, for some reason, the way it destroys the tumors, it cavitates the cancer cells, but the structures that have higher collagen, like blood vessels, bile ducts, and so forth, are spared. So it can precisely destroy tumors in locations that can't be surgically removed sometimes and can't be thermally ablated or even radiated because of the collateral damage that some of these other therapies do that this therapy seems to spare.
The thermal heat sink effect that you mentioned with RF, that's the equivalent to if you have water in a hose, you can't boil it because it's constantly being washed away.
It is, yeah.
And that would prevent the tumor from being heated up to a point where you could damage it to a point of no return.
Right.
Okay. And then in histotripsy, you touched on the mechanism of it. You're using focused ultrasound waves that are going to cause the cells to almost bubble or burst and cause cavitations within the tumor.
Yes.
This will eventually turn the tumor into a liquid or a viscous substance.
Exactly. Yeah.
What happens in the body after that?
Well, it absorbs it. So unlike thermal, which kind of causes a area of fibrosis, basically a scar, or radiation therapy, which kind of fibroses the tumor, this kind of does, as you say, it liquefies the tumor, which is interesting. And so it's almost like and it's instantaneous. It's immediate. Liquefies it like pus almost, and it looks within the space, unlike a burn. And so the body absorbs that, and it's also unique compared to thermal treatment because it on serial imaging after, it tends to collapse or regress more than on serial imaging compared to thermal or radiation burn. So it's definitely a very new, unique methodology of tumor destruction, tissue destruction.
I was going to say, I imagine you touched on before about how the liver will regenerate itself.
Yeah.
If you destroy that lesion, it doesn't completely go away, but the liver may start to grow in and shrink the actual lesion. Yeah. Are you concerned if the lesion doesn't completely go away?
Well, if it's a scar, no, it can still leave as a scar, but you don't want the cancer, of course, to completely go away. And so when it's delivered, it's also uniquely delivered. It's no needles, no probes, anything. It's a robotic system that images the tumor using ultrasound. So both ultrasound is the robot system that destroys the tumor, but there's an adjacent ultrasound that images. So it's kind of image guided using ultrasound for both the therapy and the targeting. And by the way, it can also be used. You can also do image fusion. So you can take a CT scan or an MRI scan done preoperatively and do image registration and fuse the images so you can see as you were precisely delivering it, you can actually see the MRI.
You watch it change live? Or you can
watch it change live on ultrasound.
On ultrasound, and then you can see the exact area that you are currently working on where it would be on the MRI.
Yes.
That's incredible.
And the way it's also unique, instead of putting a needle and treating it that way, you image the lesion on the guide. It's basically you do a planning intraoperative during the procedure. You plan, you mark you see the tumor, and you actually can dial in a margin at whatever you want. And it's doesn't even have to be a sphere, whatever shape one delivers, and usually try to 5 millimeter margin or whatever around the tumor to get a good margin around it. Precisely plan it, and then you start to deliver the therapy. It's interesting. It delivers ultrasound energy bursts, kind of the size of a grain of rice. And then it's just kind of, it's almost like 3D printing. It takes 10 minutes, let's say, depending on the size, to then, and then then the sphere is created, and you can do overlapping spheres. So it's kind of neat technology of how one plans it.
What kind of operative team is involved here? Is it an anesthesiologist and interventional radiology? Who's
Yeah,
involved?
for the therapy itself, we don't think it causes a lot of pain and so forth, but because we're using it in the liver now, the liver in particular, because the liver moves during respiration. And so you have to track so that the system has to be able to monitor the tumor during the respiratory motion. So typically we use general anesthesia to control the motion of the liver during the therapy, and sometimes even using so-called double lumen tube to restrict the respiratory motion of the right lung, which moves the liver more. Or we even use sometimes a jet ventilator, which is a different ventilator that doesn't cause the lung to move nor the liver to move during therapy. So as this therapy, if it does become approved and developed in other areas of the body, the kidney and other areas that don't have as much pancreas doesn't have as much respiratory motion, I think it'll still necessitate general anesthesia because there may be some pain and patient movement during the procedure, but it's not. We won't require the precision of breath motion with other sites outside the liver in the future.
Let's do a different case. So this was a curative cancer case. Let's talk about a more palliative case. So let's say, for example, we have a 55-year-old patient that has liver cirrhosis due to hepatitis C and a solitary 3.5 centimeter hepatocellular carcinoma lesion. MELD score is 12, and this patient's told they approximately have a 6 to 12 month wait for liver transplant. How can histotripsy be used not curatively, but perhaps as a bridge to liver transplant for a patient like this?
That's a great question, Nolan. I mean, first of all, the strategy for this patient, though, is curative. The goal is to cure this patient. But given the cirrhosis, the transplant is indicated for both the progressive cirrhosis seemingly and now cancer. But you're right, in this case, the long waiting list is such that we want to do yes, it's the curative therapy is transplant, but we want to do something to hold the cancer in check prior to transplant. So this is a good indication for histotripsy in that case, where we can destroy it. And there have been examples of this even early in the technology of histotripsy, where patients have histotripsy for HCC, hepatocellular cancer, and then have had a transplant later. And the explant of the liver shows no viable tumor based on the pretreatment. So it successfully destroys tumors and in patients that are candidates for transplant with cirrhosis. The other indication too, as you mentioned, hepatocellular carcinoma, is in the patient who's not a candidate for liver transplant, age, or they're still drinking, or who knows what, and they have but they still have too much cirrhosis to do surgery on. This is an good indication for histotripsy. Patients that are, because of the comorbid condition, they're not fit enough for surgery. And in the case of this, their liver, we mentioned the liver will regenerate if it's healthy, but if it's a damaged cirrhotic liver, these patients can't tolerate major surgery. And so histotripsy is a good example, even for curative intent, definitive, even in someone not going for transplant. Treatment of HCC histotripsy is a good option for those patients.
In those patients, if that HCC lesion gets too large, do they then become not a candidate for liver transplant? Is this something that could potentially save their life in the aspect of it gets rid of the cancer, which we said is curative, but also it keeps them on that transplant list?
Yeah, that's potential. Absolutely. If it grows while they're on the list or spreads, then they're no longer candidates. So one can keep that in check. Currently, I think if you treat a tumor like this, they stay on the list because having the cancer moves them up the list, for example. So you want to make sure you don't do such a definitive therapy that now they're saying, well, the cancer's treated, now we know you're no longer eligible for transplant. But usually they still are on the list.
It's more of the small details.
Right.
Yeah. Let's just say we have a patient that gets histotripsy, and then they have demonstrated regression of other areas of cancer in the body. How would this be explained?
So they have two spots of cancer. Let's say one is histotripsy. Of course, that one is treated, but now the other one seems to shrink.
Yes.
Yeah, that's been anecdotally described, and it's that concept. It's called the abscopal effect. We don't understand what that means, although everyone thinks it may have some immunologic background, in meaning that somehow that the immune system, as the one tumor is destroyed, it somehow has an impact on the other sites. No one really understands this phenomenon. It's been described for decades in other ways of tumor treatment. But what's interesting about the histotripsy is that, again, it's very new. It hasn't been studied, but at least anecdotally, there are significant descriptions of that phenomenon occurring. So it's really created a buzz. It may be we're ahead of ourselves a little bit as to whether this is a true phenomenon that somehow, just unlike thermal ablation, which destroys the tissue and the antigens and everything, or radiation, which is a slower kill of the tumor that fibroses it, this liquefies the tumor cell membrane. And so now these antigens, these non-disturbed antigens, are leached in the abdominal, leached in the bloodstream. So it's certainly theoretically an exciting concept that somehow that this form of tumor destruction can somehow stimulate the anti-cancer immune system within the patient. This concept has not been proven, and I can just tell you there have been other ablative things that people said, "Oh my God, this is this is going to happen," and that's been difficult to prove. This is a unique way that tumors are destroyed. There's some theoretical, and there are some animal studies that also show some stimulation of the immune system and potential neoantigens. So exciting, but premature to really be offering it for that indication for patients. But I can tell you many centers are now looking at whether the histotripsy can stimulate shrink tumors in the other sites. The other piece, which I know you're interested in, is, as you know, there are a lot of new therapies now of drugs that stimulate the immune system, immunotherapy. And so now that we have these, the other exciting thing is, okay, it's one thing to have a natural stimulation of the immune system by histotripsy, that you get a regression, let's say, in another site. But what if you did that therapy and combined it with immunotherapy? Really exciting. Let's not get ahead of ourselves, but needs to be studied. So I encourage any patients who if there are clinical trials looking at these questions, that patients should really think about enrolling in this trial so we can make these discoveries if indeed they're true.
Well, let's go to some myth versus medicine. How about that?
Sure.
Okay. Histotripsy is clearly the best option. I prefer it for my pancreatic cancer.
For your pancreatic cancer. All right. Well, that's a lot of patients are asking about. So right now, this is a brand new, just was the new technology of a way we described of how to destroy tissue non-invasively. And so it's been applied in cancer, and the pivotal trials were first done in treatment of liver tumors. So about 2 years ago, it was approved, FDA approved, to treat liver tumors. There's nothing unique about the liver. In fact, I even mentioned the liver moves and so forth. Other organs don't move. So there may be maybe real potential in areas outside the liver. It's just that's the first to market is the liver. So the pancreas has not been yet standard to be done. Saying that, the pancreas is a very potentially really exciting area for this therapy, because there are a lot of vital structures. Talk about the liver with the veins and structures. There are a lot of vital structures around the area of the pancreas that make the surgery more difficult, but also that makes the cancers in the pancreas inoperable, because if it impinges on a main structure, a main artery or vein, they're often inoperable. So this could be a therapy that could be very exciting in the pancreas. That, and then the kidney is another area. Tumors in the kidney often require partial removal of the kidney and so forth. And so this could be really a novel area for treating small kidney cancers, kidney tumors. So that is also, those studies have been completed already and are currently will be submitted to the FDA for approval, likely by this year. So both pancreas and liver are probably soon to come down the pike as the next. And then there's work being done down the road in prostate and breast and thyroid and who knows, all different potential areas. But right now, liver is where we use it.
But we don't want to get ahead of ourselves.
I really think we need to. Right now, that the treatment of histotripsy for pancreas is outside of a study or an exceptional situation. It is being done off protocol, but probably I think I would advise be done in the context of a study, until which time there are more data to show its efficacy.
Do you get concerned that people get ahead of themselves, use something that is unproven when there are other options and, treatment protocols and surgical techniques that have been used for years?
Yeah, this is nothing new to this therapy. This is often, a lot of things are done that may not be effective in medicine, and sometimes there are motives, financial motives, and other reasons that things are done or that patients want to. This is an interesting. This is so new, and the data is still emerging. But because it's the risk is pretty minimal comparatively to doing other things, and all these exciting things about the potential benefits that are yet to be proven, has created a buzz from patients. It's not even promoted by the industry, by the company, or financial motives, but more that patients really want this therapy. It's very safe and easy to do, and so we have to caution that until which time we have longer term data and more effective evidence to support it, we need to restrict a little bit or be careful about its overuse early on.
We have a lot of different technologies that we've talked about. We've talked about radiofrequency, obviously histotripsy, surgical techniques, robotic surgery. The last myth I want to talk about is if somebody comes to you and says, isn't this just the same as HIFU or high intensity focused ultrasound? Because it sounds similar.
Yeah.
What do you have to say to that?
Yeah, that's interesting. So HIFU, yeah, you're right. That's a therapy that's used for the prostate typically. High frequency ultrasound. That is different technique. So HIFU uses high intensity ultrasound that's focused, and then that vibrates the tissue to generate heat. So it's another form of thermal ablation. And so this is ultrasound, but it uses a lower frequency of bursts or pulses of ultrasound that, as I mentioned, cavitate the tissue, doesn't burn the tissue. So different, but often clinicians and even a lot in the healthcare community confuse high intensity ultrasound with histotripsy. Different technology.
Okay. Well, obviously, speaking of technologies, you've dealt with a lot of new technologies, the robot being one of them. These are expensive machines. Banner MD Anderson is one of the first people in Arizona to offer histotripsy as a treatment. How do you make that decision when you hear about this as an investment to make rather than just a cool new toy that may be an expense?
Yeah, because this entailed a high capital expense to buy the system and so forth. I'm proud of Banner. I'm glad that Banner really got ahead of it here rather than being ultra conservative about it. And we were early on in the adoption. Every health system sometimes adopts some new therapy earlier or later, and it's always a strategic decision about whether to do that. This is one where it does entail some capital expense up front, and yet I think I'm really glad that Banner Health and Banner MD Anderson really were one of the early adopters for this therapy. And I don't think it was always necessarily even a financial decision, but and MD Anderson Houston has this as well, and as well as among other MD Anderson partners. So I think that in part helped with that. And I think a lot of top academic centers are understanding and appreciating that this is that there's something very positive about this therapy. So I'm delighted that we were one of the first in the region to get this.
So do you all have conversations then with experts at, let's just say, conferences, or you talk to folks at MD Anderson or other places that are using this on patients, and that's where you start to see that the value is there for it?
Yeah, and even what all this, as it evolves, the data, even cooperative, doing studies that are cooperative with multiple sites can ask for some specific questions. So I think it's not just with MD Anderson, but I think many of us that are using this therapy are communicating with each other, talking, designing studies, designing trials to try to move this technology forward, collecting data. There's even a system sponsored by the company that the data is all captured centrally or can be captured, and then it's available for investigators to use to study this, almost like a registry. So it's pretty nice way for a new emerging technology to go, rather than just everybody just doing it on the side,
From a systemic way to view patients, right, and provide them the optimal care, do you feel like the recovery time with this allows patients to get back to living a normal life nearly immediately after, whereas large abdominal procedures have significant downtime?
Yeah, I think that is one of the real advantages here. There's just minimal, even compared to other non-surgical therapies, which can take longer to deliver treatment, multiple treatments in the case of radiation treatment, or with a needle, for example, with other therapies. So this seems, again, it's early on, and it doesn't have the duration of long-term data than some of these other therapies, but definitely, if done well and done safely, that it's very low morbidity. Patients they go home the same day typically. I mean, occasionally somebody will stay overnight, but usually they go home the same day, and really very, very little side effects. And they're back to work like the next day if they want. It's really which is really unusual for almost any kind of therapy. And the other piece, by the way, is that often these patients are on chemotherapy. For many of these treatments, you have to, particularly surgery, you have to stop the chemotherapy, weeks before sometimes, and then once they recover, they start the chemotherapy. One very exciting thing, you don't have to stop at all the treatment. They could have gotten chemo the same day or the next day, and you don't have to stop the cycles of chemotherapy at all while this is being done. So that's another advantage.
For patients that are in rural areas or maybe aren't near a large academic center, what's your recommendation to them, or maybe even rural primary care doctors? They think they have a patient that could use this.
Yeah, it's a good question. First of all, not every patient who has a tumor in their liver is eligible for this. There are some logistic limitations to it as well. We mentioned the tumor size. Patients come in, they have a 10-centimeter tumor. No, that's not going to be a good option. Although, at least for a curative intent for complete treatment. And also the location. It's because you have to use this image-guided system in the liver. It can't go through the lung, and some other nuances there. Not every location is amenable to this therapy. So often it does necessitate a careful review of the imaging studies to determine, is this patient eligible or not. We often do a preoperative ultrasound in the clinic to make sure that we can see it visible and all that. So often this is an issue of patients, not just rural, but patients from out of state. We get referrals or patients asking about coming here for this therapy from all over the country. And you don't want to, so often it does necessitate a little bit more sophisticated, I would say, coordination and navigation, sometimes to look at the records and look at the scans before, with a conversation to determine whether a patient may be eligible for this therapy. But often if a patient's not too far away, they may want to come in, learn about this, and see whether they're a candidate for this therapy. And if not, often then we can talk about other options. But for patients that have a long distance away and have an interest in this, or primary care referral, I think it may be often to reach out to us, and then we can review the imaging and talk about the case and determine whether a patient may in fact be a candidate.
Do you have members of your team that are dedicated to doing that?
I do dedicated a nurse and PA, and there are now three of us in our team that physicians that do this therapy, and we'll continue to grow that. So yeah.
Let's do some fun questions.
Sure.
Okay. You've lived in the Northeast, Texas, Arizona. What's been your favorite Arizona activity to do?
Well, probably hiking. Well, actually, the best thing I did, which was rafted down the Grand Canyon last summer. So that's a once in a lifetime. That's amazing. So I highly recommend it to anyone who hasn't done that before. But I would say that's not something you do every day. But otherwise, yeah, I think hiking and biking, mountain biking, I think is just a very different mountain biking in the desert, I would say, than out east. So really fun.
If you weren't a surgeon, what career would you have chosen?
Probably something like engineering or physics or something in the science field or something like that.
Hands-on building things.
That and also the science or biology or something like that.
Yeah. All right. What's one piece of advice that you would have for a medical student that may be interested in surgical oncology?
Yeah, exciting field. I think one is pursue it, find the right role models, find the right mentors, I think is really important. And it's not even surgical oncology. I think any medical student, it doesn't really matter I think I would have been happy as a psychiatrist or as any specialty. So it's just a matter of love what you do, find the right path. And it's not so much, it probably doesn't matter what area you go into. You just love what you do. And the other is focus on the patient, focus on the care we give, the relationships, and not the money, not the administrative aspects that tend to burden healthcare and medicine a lot. But if you really keep your eye on the relationship with patients, it doesn't matter. And surgical oncology is one area. And the focus on surgical oncology that I liked, as I may have mentioned, is it's very technical, which is fun. It's just like you work playing in the sandbox every day, if you will. I don't want to say that to patients, but it's very technical. That's fun to be building. And then the other is the human side of as I mentioned, the psychosocial, the impact on patients' lives and the continuity of care that surgeon often doesn't have. That is really, for me at least, very rewarding. And I think a medical student that can find that is important, I think, makes the profession still fun, in spite of everything that's difficult now in medicine. And a lot of people are leaving medicine. I think it's because of all these other burdens. And I think if we just keep our eye on what we love about the profession, it's fantastic.
All right, let's get to the takeaways of this episode. So the first one I have is that histotripsy is approved for the liver. Now, it's likely going to be approved for the kidney and pancreas soon, but we shouldn't get ahead of ourselves, and we should see what the data shows for other spots in the body. You agree with that?
I agree with that. And also for there's a lot of excitement we mentioned with the abscopal effect, immunologic, that, okay, even treating tumors in the liver in situations in which we, let's say, can you treat bigger, partially treat tumors or treat tumors that have already spread elsewhere but are also in the liver? Should we be treating tumors in the liver that without curative intent, for example, or in situations where a patient may have spread to the liver from a form of cancer that we typically don't go after locally? Should we be doing those things? So those I think we need to be a little bit cautious about overusing this in selected cases. Saying that, though, it may be very effective. So until we get data, it may be likely being used even in the liver with increasing frequency.
Yeah. So basically, we have a good indication already.
Yeah.
Let's just wait and see what the other indications show. Yeah. My second takeaway I have was actually about the abscopal effect, and that seems that it could be real, but we aren't sure yet. So let's not get ahead of other possible treatment options that we already know work.
Yeah.
And then the final takeaway I had was that if someone has someone, or that they know their primary care doctor, they have a patient, they should reach out and see if this treatment is an option, because we do have systems in place to help those people out if they are. And if they are an option, we also have other treatments that they may not know about.
I absolutely think so. Don't be both the patient and the family take charge of their situation, and may not just rely on what their what their oncologist tells them in all cases.
Okay. If somebody's watching this episode and they want to refer a patient, where do they refer to? Where's your main practice at?
I practice both at the East Valley, in the East Valley at the Gateway campus, and also at University downtown as well. And my team is also in the Northwest. Currently, the Histotripsy system is in the East Valley, in the Gateway campus in Gilbert. So to have this actual therapy currently, that's where it's being done.
Thank you so much for coming on the episode, Dr. Choti. It's been a pleasure. I want to say thanks to everybody for checking this out. If you enjoyed this, please consider subscribing on whatever platform you're using. This really means a lot to us. I'm Dr. Nolan Fisher, and I'll see you on the next episode of Beyond the Rounds. Thanks for checking out this episode of Beyond the Rounds. As always, we hope you got some clinical insights that you can take back to your patients. If you enjoyed this episode, we encourage you to follow us on YouTube or wherever you get your podcasts. We'll see you next time.